propofol, it really depends upon how you use it. If I use it for a temporary procedure, you may be a little foggy for a couple of hours, but usually people fairly quickly come back to their normal health. We use propofol on patients that are intubated and they're on a ventilator in the ICU, and they may be on a propofol drip. Propofol usage that's more than 48 hours, there are a whole host of other risks. Those people can have longer-term cognitive impairment. You can also have propofol infusion syndrome, and it can lead to multi-organ failure.
There's a drug that millions of Americans receive every year in operating rooms, emergency departments, ICUs, and procedure suites. And most people who've had it don't remember a thing. And some people don't even know if they've received it. And it's called Propofol. And you might recognize that name from the news. It became infamous after the death of Michael Jackson. But what most people don't realize is that propofol, used correctly, is one of the most important tools in modern emergency and procedural medicine. Today, on What the Health is Happening, we're going to demystify it. What is propofol? How does it actually work in your body? Why do ER doctors and anesthesiologists reach for it over other options? And what are the real risks? The one that don't always make it into the consent form. And if you've ever been sedated for a procedure and wondered, what exactly did they give me? Or if you have a procedure coming up and you want to ask the right questions, this episode is for you. Dr. V, I'm super excited about this episode. It is something I think everyone's been sedated, everyone can relate to it, and everyone knows about this from the famous Michael Jackson case. So it's great to see you. Are you excited for this?
Thank you, Layla. Good to see you too.
Good to see you. Are you excited for this episode? I know Michael Jackson's death anniversary is coming up too, so it's actually a interesting time to have this conversation also.
Yeah, and I was a big fan of his music, and I want to really demystify for people this medication and everything that occurred.
Absolutely, absolutely. I think everyone's an MJ fan. So
yes,
even though this got I think what we're going to do today is talk about obviously the medication and the side effects and also the good things about it. But it did kind of get an alarming kind of reputation through the Michael Jackson case. So let's kind of just start from the beginning. What is this medication and how did it go from a laboratory compound to one of the most widely used sedatives in the world?
Yeah, so it was first developed by a veterinarian anesthesiologist back in 1973. A lot of medications people don't realize, there's a lot of back and forth between veterinary medicine and human adult medicine. It got FDA approved in 1989. And it is basically, it's not people wonder, is it an opioid? Is it a benzo? It is really a general anesthetic. And it's a sedative hypnotic agent. That's basically what we sort of call it. And that's what propofol is. It also goes by the name of Diprovan.
Okay. Yeah, I definitely haven't heard of it used as with that name, but I know that it is a common medication in the emergency department. So, and I think I don't know how often you use it, but I know it's something that you definitely do use in the ER. So can you walk us through what actually happens in the body when propofol is administered from injection to unconsciousness?
Yeah. So if I were to start, let me tell you a little bit about when we use it. So we have people sometimes that come to the emergency department and they may have a hip dislocated, they may have a shoulder dislocated, and we have to do a procedure that might be very painful. But the procedure itself is relatively quick. And we use propofol because it acts relatively quickly. So basically, if you administer propofol and it's sort of a milky white substance, it will actually put you to sleep in 40 to 60 seconds. It has its maximum effect in about 90 seconds. And similarly, like you come back to normal very quickly when it wears off. It has a half-life of about 2 to 4 minutes. So, in a period of about 10 minutes or 15 minutes, it's significantly out of your bloodstream. So we use it for procedural sedation. It can be used for longer term sedation, and it can be given in a infusion and an IV drip format. But that's basically what we use it for in the emergency department. Those two uses.
And in the emergency department, there's a lot of drugs that can be used to sedate a patient. So why do emergency physicians and anesthesiologists often prefer propofol over other options like ketamine or fentanyl or midazolam or any other drug?
Yeah. So when you look at something like midazolam, there's no analgesia. So midazolam is just going to sedate you, but you're going to feel all of the pain associated with that particular procedure. Right. And then similarly, something like fentanyl is for pain, but doesn't provide you the sedative component. We actually do use ketamine a lot. Ketamine can be used solely. Propofol can be used solely. But they both have pros and cons. So one of the things with ketamine is that ketamine can often, some people can get very, wild dreams, almost psychosis. They can get some nausea, vomiting. They can get laryngospasm. Propofol, as you know, can cause respiratory depression, can lower your blood pressure. So what we're seeing now and what we use a lot in the emergency department is a combination of both ketamine and propofol. And it's called ketofol. And it's basically where you actually use half dosing of each for procedural sedations, and you kind of get the best of both medications, but not the side effects, or you're less likely to get the side effects, I should say.
Okay. And I know that most patients don't really know or have any idea what they're being given before a procedure. I know anytime I have been given anesthesia, I don't know what it is. We refer to it as we're getting anesthesia. No one really knows what they're being given. So, what actually happens in the ER or even the OR in terms of informed consent around propofol?
Yeah, so normally what I'm doing is I consent the patient related to the degree of sedation that I'm going to actually give them. So I will consent them. You're being consented for moderate sedation. You're being consented for deep sedation. I don't necessarily always go into the actual drugs that I'm going to use because patients often don't know the difference between the drugs. So I consent them for the type of sedation that I'm going to use.
Let's talk a little bit about the risks because they are real. They're really real risks involved. But what can go wrong with propofol, and how serious is what can go wrong?
Yeah, so the main thing with propofol is that propofol, first of all, it has to be used by the right type of physicians. That's the main thing. And when you made reference to the Michael Jackson incident, propofol is used by emergency medicine physicians, ICU physicians, and anesthesiologists, right? I don't know of any scenario where physicians without that critical care training actually use propofol in standard medical care, right? And then the other thing with propofol is that you have to be monitored. So we have a cardiac monitor, we have a pulse ox, we also have a CO2 monitor often on the patients, and we do not leave the room at all from the beginning of the procedure until the end of the procedure. So when I actually do a procedure on this patient, and let's say I'm in an emergency department and there's 20 other rooms, let's say there's 20 rooms, I've got to go do conscious sedation. I tell the other person that I'm working with, I will be in this conscious sedation because they are then responsible for the rest of the emergency department while I'm in that room. I cannot leave that room for any reason whatsoever in an emergency department until that person actually is able to sit up and talk to me again. So that's what it looks like when propofol is used appropriately by trained physicians in a setting that is properly monitored and properly monitored continuously. So in that environment, it's actually very safe.
Interesting. And I think that we touched on this before we started recording, but That's what was a big scandal with the Michael Jackson case as well, because it seems like the physician wasn't in the room the entire time or was in and out of the room or something to that effect, which is clearly something that should not
Yeah,
be.
and probably was not properly. I don't know. I don't believe his specialty was emergency medicine, ICU, or anesthesiology. Because with those specialties, the whole scenario of even doing, like, I know when I heard about it, I was shocked. I was like, how is somebody using propofol in a home? Like, it's not even like the proper setting, right? So it is only used in the emergency department, in the ICU, or in the OR. So even if a patient is hospitalized in an inpatient bed, they wouldn't get propofol. They would have to be in an ICU setting or in an OR or in an emergency department where there's access to all of the critical equipment and monitoring that we do.
Absolutely. And even just to piggyback off that a little bit, this Michael Jackson death and horrible incident is kind of what brought propofol into the mainstream conversation. I don't think many people spoke about it prior to, but it brought it into the mainstream conversation in a dark way, I should say. And
Yeah.
as a physician, do you think about how do you really think about that moment beyond what you just touched on? And what does it illustrate about the drug's potential for misuse?
Yeah, well, you know what? I think I sort of thought about it differently. I sort of thought about it in relationship to concierge medicine. There's this whole area of concierge medicine that is developing where, patients are hiring physicians directly. And particularly when that happens outside of a hospital setting or a medical group practice setting, um, where are the standards? Where are the protocols, right? And I think that, we have a lot of standard operating procedures that are in place in a hospital setting. So before I become employed by a hospital, I provide almost a 5-page list of the procedures that I'm qualified to do and what I'm not qualified to do, right? And conscious sedation is something that I'm qualified to do, right? If you where are these safeguards in concierge medicine? I think I looked at it more of, we as medical physicians actually need to create standards when it comes to concierge medicine and make sure that people are practicing in a way where the standards of healthcare are still maintained, even if you're getting that healthcare in your home. And I think I think there was too much focus on the drug and not enough focus on concierge medicine and making sure that we have standards in place so that nothing like this ever happens again.
Absolutely. And beyond that, when it comes to post procedure cognitive effects, I think that there are something about a lot of patients experience, but rarely connect back to sedation. So, what should people know about propofol fog or confusion after sedation?
Yeah, so propofol, again, it's a lot of it really depends upon how you use it. If I use it for a temporary procedure, I'm putting your shoulder or your hip back in, um, you may be a little foggy for a couple of hours or, afterwards, but usually people fairly quickly come back to their normal health. When you actually we use propofol on patients that are intubated and they're on a ventilator in the ICU and they may be on a propofol drip. And those patients then may be on propofol for days. So when you actually get to and you have propofol usage that's more than 48 hours, there are a whole host of other risks and other things that can occur. Those people can have longer term cognitive impairment. You can also have propofol infusion syndrome, which is basically where your cells don't produce energy like they should, and it leads to cell death and it can lead to multi-organ failure. So it's very rare for these things to happen, but it is a risk associated with the drug, just like there's risk associated with almost all the drugs that we use, right? And so, but yeah, we see it more with people that are on a propofol infusion and they're ventilated and they're in the ICU than those people who get a short procedure done.
And like we touched on earlier, sometimes when you are in these situations where you're going to have a procedure, you don't really know what you're going to be getting. So for listeners who do have a procedure coming up, is there anything from a colonoscopy to surgery? What is the conversation they should really be having with their provider about the sedation choices?
Yeah. So the main thing is there going to be an anesthesiologist on my case? Right? Because if there's going to be an anesthesiologist on your case, then you have somebody who is trained and then will meet you before the procedure is done and then go over what are the different sedation choices. Right. And so they'll go over not only medications, but the other thing that we're seeing a lot is we're seeing regional blocks used. So regional blocks are similar to when you go to the dentist and you get Novocaine and you get dental work done. We are using a lot of regional blocks now to deal with pain related to hip fractures or various procedures that you're getting done. So I think that you have choices now, and they will sometimes ask you, do you want a regional anesthetic where we block the nerve regionally, or do you want to be completely put under? One thing about regional anesthesia is you can still hear what's going on. Right. So some people don't want to, I don't want to hear anything. I want to be completely out. And again, it depends upon what the procedure is. So yeah. So the main thing to ask is, do I have an anesthesiologist? And when will I be meeting him? And then you can actually talk with him about the different drugs and the different options that you have. If you're told no, you do not have an anesthesiologist, then you can ask, well, what medication am I going to be given? Because if you do not have an anesthesiologist, then you are more likely to be given something like fentanyl or midazolam. Those are drugs that other physicians can use, but propofol is specifically for someone who is ICU, emergency medicine, or an anesthesiologist.
That's such a important thing to know. I think that when people think about getting a procedure, or maybe this isn't just me, but I think that this would be common for most people. You worry about the procedure, you know you're going to get some kind of anesthesia, but it would never cross my mind to think about connecting and speaking to the anesthesiologist or really asking what you're getting. I think you usually have more nerves and more concern about the procedure itself than the actual anesthesia. So it's interesting to think about. I think it's really important that people know that, so they know what they're getting and they know their options and they have that trust and that information about what's happening beyond
Yes.
just the procedure.
Yeah, your anesthesiologist should absolutely meet you before your procedure, right? And in the emergency department, there's certain things that we do. When did you last eat? We have you open up your mouth, so we make sure that if we did have to intubate you or put you on a ventilator, it's easy to do. So yeah, I mean, every procedure that I've gotten done, I had a hip replacement, a hysterectomy. I met my anesthesiologist ahead of time. It was the same day as a surgery, and maybe about an hour or two before the surgery, and we went over what my options were and chose things. That's when things are being done correctly.
Yeah, I'm thinking back. Luckily, I haven't had a lot of procedures, but either I'm completely forgetting, which I don't know if I ever really had a conversation with an anesthesiologist. So
Right.
that's interesting. Or maybe I've had questions asked, like, for example, when was the last time you ate? But even the thought process surrounding of really connecting with an anesthesiologist first is important and good to know. And for the final word, what do you want every listener to take away from this episode?
Well, I think the main thing to take away from this episode is that, propofol is not a medication to be scared of in the proper hands. And that's really one of the main things. I think the other thing is that, if you are looking at hiring a concierge physician or you're looking at hiring, a physician directly outside of a practice, outside of the hospital, you really want to make sure that that they are following the protocols and the standards of medical care that they would follow if they were practicing in a hospital, right? And you can ask them that question. A lot of times, physicians will say, no, I don't feel comfortable doing that. And, you don't want to actually try to find the physician that will do what you want. Instead, you want to look at why did three other physicians say they would not do this for me? right? And is that a risk that I really want to take? And listen, I really hope, I think there's still time for us as a country to really put some parameters around concierge medicine, because you cannot expect the patient to actually know what's right or what's not right. They just want what they want. Right. And I think it's really, really important that there are some parameters and some standards of care put around concierge medicine, because otherwise, you know, we've had cases, we've had cases since then. Was it Matthew Perry? Was it Matthew Perry from Friends? Yeah, Matthew Perry. Yeah, Matthew Perry from Friends. There was a physician involved, and we really need to have some standards of care when it comes to concierge medicine, so that people who are actually hiring physicians in this manner get the same quality of care that everybody else gets, and this is less likely to happen. I think that's what's really important.
Absolutely. And what you said, patients, they want what they want, but we don't know what's best as a patient, especially if you're
That's
a
right.
patient with no medical knowledge or training. You need the physician to tell you what you need, because what you need is usually not may not be best for you at all.
That's right. That's right. Yeah,
And I think
absolutely.
with concierge medicine, and I worked at a concierge medical practice for a while years ago. And I remember interacting with patients, and it's exactly what you said. They want what they want, and they're willing to, pay this and do whatever for what they want, and for whether it's a convenience or whatever it may be. But when it comes to something as important as anesthesia, it's definitely important for the doctor to say, no, this isn't best, or something to that effect. Like you said, why would 3 doctors say no, and then a concierge physician, for example, say yes? So it's really
Right.
important to find the right physician and also know what's going on, for sure.
Yeah, the goal is not to get a yes to to what you want. The goal is to actually get the actual information that is actually best for your overall health, right? And I think that we've really done patients a disservice by not having some standards on concierge medicine. We really need to have some standards.
Absolutely. And I think the key takeaway of this episode is that Propofol is not a scary drug. In the right hands, in the right setting, with the right monitoring, it's one of the safest and most effective tools that we do have. And medicine works best when patients are informed, like we talked about, and knowing what you're being given, understanding why, and asking the right questions before any procedure. That is not being difficult. That is being your own advocate. And that's exactly what this show is here to help you do. And if this episode gave you language to use in your next doctor's appointment, share it with someone who has a procedure coming up, and make sure you remember it for your own care. And everyone deserves to walk in being informed. Make sure that you do follow the show so you don't miss what's next. And until then, stay curious, stay clear, and take care of yourselves. Thank you so much, Dr. V. I will talk to you soon, and we'll see you in the next episode.